It's a pleasure to have the opportunity to talk to you about this issue. And I like to wrap it around the story of the taming of the wild west of managed care, a toolkit for leveraging legislation, litigation, and advocacy. So first, some disclosures. Look, I have served as an expert witness in class action and other lawsuits addressing issues raised in this presentation, including serving as the expert in adult psychiatric disorders in Witt versus United Behavioral Health. The opinions expressed are my own, not necessarily those of Austen Riggs. And although I'm a member of the APA Board of Trustees, I'm not representing the APA here. I'm representing my perspective on these things. But I wonder, for those of you who are clinicians who have dealt with the world of managed care, I wonder if you're familiar with this kind of denial of care. The treating clinician who's focused on recovery says to the utilization review clinician, who tends to be focused on stabilizing crises, hey, my 25-year-old patient, Susie, has depression, anxiety, post-traumatic stress disorder, borderline personality disorder, and alcohol use disorder, with multiple failed medication trials, hospitalizations, and suicide attempts. She has performance difficulties at work since her symptoms got worse and is struggling to remain alcohol-free. The 20 sessions you authorized are nearly gone, and I'm requesting 20 more sessions over the next 10 weeks. I want to see her twice a week, given the trouble she's having. And I thought we'd add an IOP to help her make gains so she can use outpatient treatment better. To which the utilization review clinician says, well, the IOP is not really medically necessary because she's not currently in crisis. We will give you 6 more sessions over the next 2 months. However, if she continues to drink, we will approve no more sessions after that. And of course, I always want to say, wait a minute, if we were talking about a diabetic who wasn't following their diet, would you be telling me you might stop coverage? But that's actually a different presentation about a different issue in mental health parity. So what's really going on here? How do we make sense of this different kind of experience, this often painful and frustrating experience that we have if we're speaking to utilization review clinicians? It's a question of contrasting the clinical and the insurance perspectives on what exactly the goals of treatment are. So I'm going to talk about that, and then I'm going to review some of the relevant legislation, explain the relationship between medical necessity and so-called generally accepted standards. And then I'm going to summarize the Witt versus United Behavioral Health case, its verdict, and the opportunity it gives us to take action. So let's start. What's the goal of mental and substance use disorder treatment when clinicians think about it? MSUD is mental and substance use disorder. Well, we know that many patients struggle with chronic or recurrent disorders. They have comorbid disorders. If you remember a few slides ago, Susie's situation, it's not so unusual. Multiple different things: anxiety disorders, post-traumatic stress disorder, personality disorder, substance use disorder. That early adversity or recent trauma is often part of what people are struggling with. And our evidence-based treatments work, but the fact is they have been tested and developed on the roughly 20% of patients who have a single disorder, not the 80% who are more like Susie and have the complicated, complex comorbid presentations and a history of trauma. I call these the unicorn patients compared to the horses that are really what you find on the prairie. And we know that there's a higher evidence-based treatment failure rate when there is comorbidity and when there are adverse childhood experiences. This is well established in research. Given this reality, the generally accepted goal of treatment for clinicians is improvement in the patient's functional status to achieve what's called recovery. So what do we mean by recovery? Well, SAMHSA helps us here, and it tells us that recovery from mental and substance use disorders aligns with generally accepted standards. I mean, if SAMHSA is saying this is what it's about, you can assume it's pretty widely accepted. And recovery is defined as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So the key is it's a process over time, and it's about living a self-directed life. There's nothing in here about simply stabilizing crises. Now, when we think about the provision of treatment, the same 3 levels of care exist, whether it's medical surgical treatment or mental and substance use disorder treatment. There's inpatient treatment, there's outpatient treatment, and in between, there are intermediate levels of care. Let me illustrate what I mean about this with a medical example. If grandpa has a stroke and is neurologically unstable, he goes to an inpatient unit. He may be treated in the intensive care unit, he stabilizes. And then we'd all like to see grandpa go back to an outpatient treatment where he can continue to recover from his stroke. But what if grandpa cannot talk, walk, or dress himself? Well, then he needs to go to an intermediate level of care to focus on improving his functional status. I'm not talking about a nursing home for long-term extended housing and a chronic settling for what's not working. I'm talking about an active effort to get grandpa walking, talking, and dressing himself again. The same 3 levels of care hold in the world of mental and substance use disorders. Inpatient level of care for crises, we'd like most people to be in outpatient treatment, but sometimes we use intermediate levels of care to improve functional capacity. And according to the law, the final rules of the federal Parity law, the intermediate levels of care are residential treatment centers, intensive outpatient programs or IOPs, and partial hospital programs or PHPs. Now, we'd like everyone to be in outpatient treatment if they're not in crisis. But in order for outpatient treatment to work, and it is the usual road to recovery in mental and substance use disorder treatment, but in order for it to work, the patient has to have 2 skills. They have to have the capacity to use the sessions, whatever they are, med management, psychotherapy, groups, whatever they are. They have to be able to use the sessions, and they have to be able to function adaptively between the sessions in terms of work and relationships. These are the skills that someone needs to be capable of in order to have outpatient treatment work. But if one or both of those skills are impaired, what we generally do is we add services. We add medications if it's been only therapy. We add therapy if it's been only medications. Or we may increase the dose of medications or increase the dose of therapy with more frequent sessions. These are things we add to try to help somebody better use outpatient treatment and manage between the sessions. We may add skills training. We may add group or family treatment. We may add treatment of substance use disorders or other treatment of comorbid disorders. And eventually, if we've added about 8 to 12 hours a week of additional services, it becomes an IOP. And if we've added about 20 hours of additional services, it becomes a partial hospital program or PHP. But sometimes adding services isn't enough. And if a patient's in crisis with an imminent risk of harm to self or others, we shift to one of the 24/7 immersion kinds of treatment, inpatient being the most frequently known. And the goal here is crisis stabilization and then a return to outpatient if possible. However, for some people, as with my example of grandpa having the stroke, for some people, outpatient treatment isn't going to be able to work because they can't do one or the other of the 2 things that are required for outpatients. Usually they have trouble functioning adequately between sessions and they're always in crisis or recovering from crisis or just plain stuck and not able to pursue recovery. For those people, intermediate levels of care like residential treatment, IOP, and partial hospital programs, but here we're talking about the immersion example, it would be residential treatment, to help grapple with the underlying issues interfering with outpatient functioning. For example, the presence of comorbidity, adverse childhood experiences, or recent trauma. And the goal of that kind of immersion in treatment in an intermediate level of care is improved functional status to achieve recovery. That's why people come to Austen Riggs. That's why people go to the dorm. There's something about outpatient that is not working. They're either stuck or bouncing in and out of crisis. They're not moving toward recovery. So some of you are probably old enough to remember that managed care expanded in the 1990s rather dramatically. And it did so in response to a number of things. there really had been quite a period of double-digit inflation in healthcare costs. It was really untenable. And when William Jefferson Clinton became president in the early 90s, he appointed Hillary Clinton to try to put together a national health insurance effort, but that failed. And after that failure, managed care expanded dramatically, and there were no rules. Nothing guided the terrain. This is why I think of it as like the Wild West. Insurance companies decided to dramatically reduce access to care in order to tame the cost. Now, recovery is the treatment goal within generally accepted standards among clinicians. But when managed care expanded in the 1990s, insurance entities substituted a different goal, the goal of crisis stabilization. And in the then unregulated Wild West, they were free to do that. There was nothing that said they couldn't choose to limit treatment to crisis stabilization. And now the question is, well, over the time since then, has the law changed the landscape toward taming the Wild West? And I'm going to suggest to you that it has. I think the first big change was the 2008 Mental Health Parity and Addiction Equity Act, the so-called Mental Health Parity Law. That 2008 law said that, look, if, and it was a big if you include coverage of mental and substance use disorders in your insurance policy, then barriers to access it cannot be substantially more stringent than barriers to access medical and surgical treatment. And it specified that this can't be, the barriers can't be more restrictive in terms of quantitative limits, so-called QTLs, like there used to be lifetime dollar amounts or lifetime days you could spend inpatient, but also non-quantitative limits, like higher utilization review hurdles, relentless reviews about whether care is going to be approved for another several sessions or several days. And then as a kind of a final moment of the Mental Health Parity and Addiction Equity Act, in 2014, the final rules were issued, which made it quite clear that parity also applied to access to the intermediate levels of care, IOP, residential, and parity. The next law that came along and that serves a role in the potential taming of the Wild West was Obamacare, the 2011 Affordable Care Act, which made mental and substance use disorder treatment part of the essential benefit package, which reinforced the applicability of mental health parity, which forced the disclosure of previously secret utilization review guidelines used to deny care. So since the Affordable Care Act, if you're turned down for care, if you're a patient or a clinician, you at least are told what are the criteria you were seen as not meeting. But there was really minimal enforcement of the quantitative and non-quantitative limits associated with the mental health parity law, even after the Affordable Care Act and the parity law. I think this is probably because the Obama administration simply needed its alliance with the insurance industry to develop the Affordable Care Act exchanges. And so there wasn't much in the way of enforcement of the parity law. And since parity enforcement was not happening from the top down, over time, it began to happen from the bottom up. Class action lawsuits against large insurance companies emerged based on their criteria for access to care. And the question really is, well, can both the combination of the top down and the bottom up forces, legislation and litigation, tame the Wild West of managed care? So let's get into this a little bit. Let's look at health insurance contracts and what they actually say about medical necessity. Medically necessary treatment, according to the AMA, the American Psychiatric Association, widely accepted definition of medical necessity, is that it's the provision of services or products that are in accordance with generally accepted standards of medical practice. Generally accepted standards then become the key to medical necessity. Let's be clear, there's no one source of generally accepted standards. It's not a single list, it's a domain. So for example, prefrontal lobotomy is not within generally accepted standards as a treatment of schizophrenia at the current time. Leeches are not within generally accepted standards. Neuroleptic medications are within generally accepted standards for the treatment of schizophrenia. So it's a domain rather than a single list. And this domain of generally accepted standards generally might be thought of as having 4 components. There's the research evidence. There's input from professional organizations. For example, the American Psychiatric Association Clinical Practice Guidelines or the American Association of Community Psychiatrists Locus, which I'll say a bit more about in the future. And then there are practice patterns. Do we do 45 or 50-minute hours? The 15-minute med check has become part of a generally accepted standard, although it puzzles me as to why, since there's no evidence for it. And then there are some other sources, like, for example, the Medicare manual, simply because it covers so many lives. And, it's not all research evidence, although research evidence is part of it. For example, in cardiology, a really science-based, research-intensive area of medicine, only about 11% of the 2,400 guidelines have the strongest research evidence. About 80% are professional society recommendations. In psychiatry, last estimate I heard, it was about 8% are really solidly research-based. So it is a combination of, yes, what's the research evidence, but also what do the professional organizations say when they seriously look at what's the best we know about how to be of use to people. Now, I mentioned the locus, which is the level of care utilization system developed by the American Association of Community Psychiatrists. It's an example of a professional society perspective on determining level of care. I don't know how many of you use it. It may be the first time you're seeing it, but it's used in most states and several other countries to determine level of care. And it's not that the locus is the generally accepted standard, but it is within generally accepted standards when it comes to citing level of care. And I mention it partly because the locus is often cited as the very first publication in their bibliography when they're publishing their utilization review standards. The trouble is they don't follow it. They cite it, but they don't follow it. The locus actually has 3 components that look well beyond crisis stabilization toward recovery. It says that if you're going to think about what level of care is appropriate for someone, you really should look at 6 different dimensions. They include safety, yes, and functional capacity, but also the presence of comorbidity, response to previous treatment, the recovery environment that the person will go to when they're home, what their strengths are. And it really looks at 6 dimensions, well beyond crisis alone. And then the locus also describes levels of care from basic outpatient through intensive outpatient and partial hospital and residential, all the way to inpatient hospitalization. And then it offers a quantitative methodology to rate the appropriate level of care based either on the total score across all 6 dimensions, or sometimes there are override scores. If you get a high score on this one, then it bypasses some of the others. Now, however, although the locus is within generally accepted standards with its use of 6 dimensions, when it comes to insurance entities, the standards used are much more restrictive. They focus on crisis stabilization and not recovery. They limit access to care to the current problem and then reduce or end services by and large. And access to intermediate levels of care are also limited to a focus on crisis stabilization, not on the proper goal of improvement in functional status to use outpatient treatment better. I like the analogy of the pot boiling over. The managed care world says, oh, your pot is boiling over. Let me take off the lid and stir it a couple of times, and that will settle things down. We'll get rid of the crisis. What they don't do is allow the work that turns down the flame. So I hope you're with me on this so far. So I've just made this assertion that insurance entities, by and large, do these things that are outside generally accepted standards. And you might ask, well, what's the basis for this assertion? Well, my personal review of the utilization review criteria from 3 major insurance entities, one of them being United Behavioral Health, and 2 independent organizations that sell mental and substance use disorder criteria to utilization reviewers. In addition, I'm going to point you to an insurance industry website that asserts what intermediate levels of care are for and says they're limited to crisis stabilization and not to working on improving functional status. And finally, I'm going to show you the missing mental health credentials among the people who develop these access to care criteria for mental and substance use disorders. First, about my personal review. I suppose because they were looking for an expert on residential intensive outpatient and outpatient treatment, the attorneys for the plaintiffs in Witt versus United Behavioral Health found their way to me because I've been at Riggs for a long time. And so I served as plaintiff's expert on generally accepted standards for those levels of care. And although the locus, which is within generally accepted standards, attends to 6 dimensions to determine the appropriate level of care. If you look at the utilization criteria of the insurance companies, it's largely limited to acuity, severity, risk of harm. Again, even though they will cite locus as a source document to justify their selection of standards. And then what does the insurance industry itself say? Well, the kind of trade organization of insurance companies is called AHIP, America's Health Insurance Plans. It's the National Trade Association representing the health insurance industry. It includes about 175 plans from around the nation. Their vision, available on their website, is that AHIP advocates for public policies that expand access to affordable health care coverage to all Americans through a competitive marketplace that fosters choice, quality, and innovation. AHIP sounds pretty good. But if you go to their website, actually, since the Witt verdict, it's been removed. But on their website, prior to the Witt verdict, was a white paper addressing intermediate levels of care in mental and substance use disorders. And it said that, look, in medical and surgical disorders, intermediate levels of care improve functional status among people with impairments that, while significant, are not acute crisis. This is the grandpa after the stroke, but he can't talk, walk, or dress himself. But look at what they said about mental and substance use disorder intermediate levels of care. These are designed to support acute management of patients. They often serve as alternatives to inpatient care and are intended to have the ability to address acute symptoms and provide crisis stabilization. Well, that's just wrong. By the way, the author of this paper offering this perspective on mental and substance use disorders is an internist with specialty training in geriatrics, no psychiatric background of any kind, but offering the AHIP perspective on intermediate levels of care in mental and substance use disorders. Finally, let's look at the credentials of developers of behavioral health criteria. Here's an example. Mcg Health, a member of the Hearst Health Network, their behavioral health criteria are developed by 9 clinical editors, and as the members primarily responsible for the creation of their content, they possess a wealth of knowledge in many facets of the healthcare industry, from behavioral health and internal medicine to population health analytics to case management. 9 clinical editors. Well, if you look at the 9 clinical editors, 6 are physicians, not one is a psychiatrist, 1 is an actuary, and 2 are nurses who do not have mental health credentials. An odd way to select a group to develop behavioral health criteria and leaving no big puzzle about why they might be off. So look, this is what I'm suggesting, that the generally accepted standards for mental and substance use disorder treatment that's used by insurance entities simply differ from the ones familiar to clinicians. Insurance entities focus on crisis stabilization and not on recovery. They limit access to care to the current problem and then reduce or end services when those are resolved. And they focus intermediate levels of care on crisis stabilization. The pot is boiling over and no one is ever working to turn down the flame. By the way, one of the problems of our system with many, many insurance companies is that the average American stays with an insurance plan just a few years. And so they inevitably have an incentive, the insurance companies, to just kick the can down the road. If I treat the crisis, maybe the next time there's a crisis, this person will be covered by a different insurance company, or they'll have become so disabled that they're on Medicaid or Medicare or something else. Single payer would be a lot better in that sense, although you have to watch out for the devil in the details. If we could do Medicare for all tomorrow, the parity law does not apply to Medicare. So it's always complicated. Actually, intermediate levels of care became kind of the canary in the coal mine that alerted us to something going wrong in the way that insurance companies compared to clinicians were looking at things. I want to be clear that managed care operates with the same moral imperative as the environmental movement. There really is a world of limited resources. And this is true whether it's the amount of greenhouse gas the Earth can absorb without global warming or the costs of healthcare. But when we recognize the problem and try to manage the limited resources, we still have to function within generally accepted standards. If health insurance contracts guarantee coverage for treatment within generally accepted standards, and most of them do, then the question is whether use of flawed generally accepted standards for mental and substance use disorder treatment constitutes a breach of contract. This is the claim that was made by the 11 plaintiffs in Witt versus United Behavioral Health for 3 levels of care: outpatient, IOP, and residential services. And they were certified as representing a class of over 60,000 individuals. Well, this is language from Judge Spiro's 106-page verdict in Witt versus United Behavioral Health. The court finds that in every version of the guidelines, there's an excessive emphasis on addressing acute symptoms and stabilizing crises while ignoring effective treatment of underlying conditions. In each version, the defect is pervasive and results in a significantly narrower scope of coverage than is consistent with generally accepted standards of care. In his verdict, Judge Spiro listed 8 elements of effective treatment. You've got to treat the underlying condition. You got to treat co-occurring disorders, not just the disorder that leads to the presentation. Sure, the treatment should be the least intensive and restrictive level of care, but only if that is also equally safe and effective. When there's ambiguity as to the proper level of care, err on the side of caution and put the patient in the higher level of care. These are the judge's elements of effective treatment taken from the testimony in the trial. Effective treatment includes services needed to maintain functioning or prevent deterioration. Those are adequate goals for treatment. Duration of treatment is based on individual needs with no specific and arbitrary limitations. The unique needs of children and adolescents must be taken into account. And when determining appropriate level of care, a multidimensional assessment that takes into account a wide variety of information about the patient is what is within the standard of care. And that's the kind of instrument that the locus is, for example. Now, Patrick Kennedy has called this verdict a game changer. And it's important for us to recognize that this is not just a good news story, but that actually this verdict is a powerful tool for taming the Wild West of managed care. But it's not going to happen unless we find ways to play a role in it. There are strategies for changing the game. We have to figure out how to expand the Witt verdict beyond United Behavioral Health to other insurance plans so that it's also applicable to other ERISA plans, the kind of plan you get through your job, that it's applicable to commercial insurance, to Affordable Care Act plans, to Medicare, and to Medicaid. If we can expand the verdict and the acceptance of these 8 elements of effective treatment, for example, to all these kinds of insurance, then we will have increased implementation of the mental health parity law, increased access to care, and decreased the really shameful health disparities in this nation. And there have been some signs of the larger states leading the way. In California, Senate Bill 855 was signed into law several months ago. It is built on WIT and its verdict. The New York State Office of Mental Health issued new insurance regulations after the WIT verdict that was based on the verdict. And in last December, the Consolidated Appropriations Act amended the parity law to require insurance companies to report their own report card on how well they are doing with parity compliance. It's that old notion of sunlight being the best disinfectant. Our professional organizations have a role. If we're members of the American Psychological, the American Psychiatric, the National Social Work Organization, whatever guild it is, the role is to endorse, to educate, and collaborate to amplify the verdict in WIT. Endorsing the verdict means, professional organizations influence generally accepted standards. So endorsing the 8 elements of effective treatment is a powerful step. Educating, teaching the membership, offering CME activities like this to introduce people to the notion of the 8 elements of effective treatment and learning how to use them when you're doing a utilization management review. There are also appeals toolkits we have one on our Austen Riggs website, and the National Council on Behavioral Health, which recently changed its name to the National Council on Mental Well-Being, also has a toolkit that we help them develop. And collaboration among the professional organizations as well as with consumer organizations like NAMI is utterly essential. We have to find a way to come together and bring and have an impact. Of course, United Behavioral Health is appealing the verdict against it, which imposed a 10-year injunction with a special master requiring them to, who will oversee their use of the proper standards of care. I'm very pleased that the APA, my APA, the American Psychiatric, filed one of the 4 amicus briefs that are part of the plaintiff's case in the appeal. And of course, our friends at AHIP, America's Health Insurance Plans, filed a brief on behalf of United Behavioral Health. So Judge Spiro is a kind of new sheriff in town. And I think we have hope of taming the Wild West of managed care using this combination of legislation and litigation if we're prepared as individual clinicians and through our professional organizations to do our part. And with that, thank you, and we'll have discussion and try to address questions in the time remaining, and I will stop sharing my screen.
Thank you so much, Dr. Plakun. That was super informative. I've been kind of furiously scribbling notes that probably only I could read if anybody saw this sheet of paper in front of me. There's just so much important information here. And we have had actually a bunch of questions come in through both the Q&A and in the chat. And I want to make sure that we get to everybody's questions because clearly there's a lot of interest in what you were talking about. Before I get to the questions, I just wanted to ask you a little bit more, because this whole notion of, and a lot of people that are attending here today, and a lot of people that work at places like the Dorm and Austen Riggs are clinicians. We went to school to be clinicians and to work one-on-one with clients. And we come to learn in the one-on-one work that we can't do the work that we want to do because we're being hindered by insurance companies through UR reviews and through them not understanding that there's a big difference between crisis stabilization and recovery. And I don't know that it's necessarily innate to many clinicians to sort of know how to participate in advocacy efforts. And it can feel quite even overwhelming to start that advocacy effort. I loved how you talked about doing things like you can amplify the message, you can endorse, you can educate, you can collaborate. But what other concrete suggestions, even like little things that clinicians who are already overwhelmed with large caseloads can do to help create broader systemic change and step outside of like the micro level work that they do?
Yeah, it's a great question, Amanda. So, I think there are things we can do for our patients and things we can do for our individual patients. And then I think there are things we can do that go beyond individual patients. Becoming familiar with the 8 elements of effective treatment. And if you're doing a utilization review call, being able to point out to a utilization reviewer, are you aware that the position you're taking is not consistent with a verdict in a federal class action in which, following these principles that you follow, insurance company, was found to be unlawful and outside generally accepted standards? They're not hard to master. The notion that you should treat the underlying and the comorbid conditions, and when there's ambiguity as to the level of care, err on the side of caution. Another thing you can do to help your individual patients is become familiar. I mean, we do this at Austen Riggs. We've become quite familiar with the locus. And we do a locus score on just about every patient. And when we have a disagreement with the insurance company, we say, well, you say no, and we say yes. Let's see what an independent objective standard says. And it makes a difference. We're seeing an increase in days covered by insurance companies as a result. There are, as I mentioned, toolkits that are available on our website and the National Council of Behavioral Health that help with this. But beyond that, I came into this work because I wanted to make a difference with individual patients. But we have to get our professional organizations to stop the abdication of generally accepted standards to the insurance companies and recognize that they're not the ones who set it. And we have to find ways to use that voice. Obviously, not everyone's going to be prepared to do that, but we need to say to our professional guilds, hey, are you aware of the Witt verdict? Are you following what's happening? Are you embracing and endorsing the generally accepted standards of effective treatment that the judge highlighted? I think there are things we should definitely do that can make a real difference.
Mm-hmm. That's super helpful. I love the concrete piece of advice in terms of when you're actually on the phone with that utilization reviewer to sort of say to them, are you aware of locus? Are you aware of the Witt decision, to challenge them? And sometimes I think too, even, because you don't know who you're necessarily getting on the phone, you might need to ask to speak to their supervisor and then restate the message to the supervisor until you get up, the chain. I don't think they're necessarily used to being challenged, and the more that we can challenge, that is advocating for our clients. One more quick question. I know that you said that the Witt decision is being appealed. I'm wondering if the decision holds up, and this might be more of a legal question that's outside our scope, but can the decision, or will it be used as precedent to sort of help other lawsuits get legs against other insurance companies, or even to expand this verdict? And we had a question about this, expanding the Witt verdict to Medicaid. Like, can this be truly precedent setting?
Yeah, well, I think that's part of, yes, I think it can be. And if the professional societies reassert their authority over generally accepted standards, and say that, as a matter of fact, the judge got it right, that the 8 elements of effective treatment are right, regardless of what happens in the appeal, then that should extend that across all insurance companies and make its way indeed to Medicaid, which covers many of the marginalized population in our country. So that's certainly something that's important to do. The other, there was some other piece that I wanted to address in this. Well, perhaps it'll come back to me. It was a long question and I lost the beginning of it.
Okay. I'm going to read some other of these questions that are coming in. We had one of our attendees ask, why would parity not apply under single payer? Single payer is a work in progress. Could it not include parity?
Of course it could, but we have to remember that when we say, what I said is, if we could start Medicare for all tomorrow, parity would not apply. We have to recognize that if we were to move to single payer, there is work to do. Remember, the Medicare law was written in the 60s and 70s, most of its language. And so that was well before the parity law. And so it predates it. And, so we would have to make the parity law applicable. So there is simply work to do. I think that it would, I'm not speaking against single payer. I think that's a good solution, because then there really is a lifetime incentive to make a difference and pursue recovery. By the way, one other thing that individuals can do, I actually have a paper in press on this now, is a dad from the Midwest who had a horrific time getting his daughter residential treatment is co-authoring with me an article on clinicians developing a medical necessity letter as a standard instrument to keep in your patient's file, to go over with your patient and the family, and to send in with insurance claims. It's another thing we can do. It's more work, but once you get used to it and have a kind of a template, it's useful.
Yeah, it's frustrating because I think as a clinician, you watch as, your clients that you're working with and your patients, it's almost as if they're getting punished for getting better, because if you get better, you're not going to get the services, but we all know that services need to extend for a period of time as you're getting better, and not just end the second that you show some signs of symptom relief. And it puts you as a clinician in a position where, you kind of want to fudge what's really going on so that they can continue to get the services they need, even though they're getting better.
Yeah, well, that's the issue of crisis stabilization. Crisis over, so we're ending care.
We're done. Yeah.
And then, and we always have to try to search for that sweet spot,
right,
between getting better and oops, it's a chronic patient and not getting better. Although remember, one of the elements of effective treatment is treatment focused on maintaining functioning or preventing deterioration.
right.
Insurance companies tend to want to see progress, every 48 hours. Now, everyone, I think all psychiatrists know, and I think probably most clinicians know, the completely irrational experience of speaking to a utilization reviewer and they say, well, you have to change the medications. You have to do something. Well, but it takes 3 weeks for the medication to have an effect. We haven't given it 3 weeks. We've given it 36 hours, but you have to make a change. And we've developed this irrational way of functioning. It's really about abdication and reclaiming our authority. We can do it. It belongs to us. We have to hold that in mind and recognize it.
Absolutely. And collaboration is going to be key on that, because it's going to take a village to fight this battle.
Yeah. And one other thing I remembered what I wanted to say, which is there are in fact other lawsuits against other insurance companies that are unfolding. And although I'm not a lawyer and I can't address fully the legal issue, here's what I'm given to understand. This is not new law. This is a breach of contract case. It's fiduciary duty. You made a contract, you promised you would provide medically necessary treatment according to generally accepted standards, and you didn't. What I'm told by the attorneys is there's a relatively little chance that the verdict would be overturned. It's much more likely that the 10-year injunction would be reduced to a 3-year injunction or something like that. So I think this case is probably in a very hopeful place. But look, as a lawyer, I am a terrific psychiatrist. It's not my domain.
Absolutely. One other question that we had, I'm just going to read it word for word, is how can insurance companies like Blue Cross Blue Shield deny coverage for RTC, which does not have 24/7 nursing, when RTC licensing in California does not require 24/7 nursing? How is there parity in healthcare coverage in states like Texas and Colorado that do not have licensing for primary mental health other than hospital crisis stabilization?
It's a complicated question, but a very good one. So look, faced with the verdict, the companies like United Behavioral Health, which has revenue annually about $270 billion, that's with a B, dollars annually, they've said, look, we have to find other ways of restricting what we pay. So they have often, and we just went through something like this here at Riggs. They will say, well, we want to know every group you run, every staff member who covers the group, and what their licensure is, and a detailed schedule. And to which we have said, wait a minute, we're licensed by the Department of Mental Health of the state of Massachusetts. We're fully accredited by the Joint Commission. We are not an in-network provider. We don't owe you this information. In other words, they will take a stance as if you are an in-network provider. And if you are required to adhere, you're required to provide them with certain information. But as an out-of-network provider, we're not. We said no, and we told them we were prepared to let the special master appointed by the court know that they were doing this to us, and they backed off. I think that what I would recommend, if an insurance company like Blue Cross Blue Shield somewhere is requiring unusual standards for licensing, I would pull out the locus, and I would say, here's a generally accepted standard, and it describes this level of care, residential. It's, I think it's, I forget if it's level 5 or level 4, medically monitored residential services. And if you're conforming to what's required by the locus, then you have a very good basis for suggesting that Blue Cross Blue Shield is not following the generally accepted standards. It's setting the burden too high. We're thinking of launching an intensive outpatient program in Massachusetts in the not too distant future. And I've learned that Blue Cross Blue Shield of Massachusetts requires that access to IOPs. They say, sure, we cover IOPs. We use acute inpatient standards. Well, that's ridiculous. That's that issue of requiring crisis stabilization to access a treatment that's not focused on crisis stabilization. So becoming knowledgeable about this, knowing the rules and being able to push back is I think, to the extent people can, it's a very worthwhile thing to do.
One of our attendees is saying that United uses ASAM criteria. Some insurance companies use Interqual, some use MCG. It seems like the ones that use Locus are primarily in New York. How do we reconcile when insurance companies are sort of using different criteria? Can we always go back to Locus, or do we have to sort of figure out which criteria they're using?
Two examples of generally accepted standards for level of care criteria were part of the Witt verdict, the Witt case. The ASAM criteria are for people with substance use disorders. They are a much better fit for determining level of care for substance use disorders. Since we don't treat primarily substance use disorder, we treat it as a comorbid condition. We're primarily treating people with mental disorders. We use the locus. So the ASAM is really a terrific one for substance use disorders. Locus is really good for mental disorders. Then there are the MCG criteria. You saw the 9 editors who developed the MCG criteria, not a single psychiatrist. And the Interqual. Frankly, they are crisis focused. They are among the instruments I have reviewed in some detail. They are crisis focused. This is why the new law, SB 855 in California, and the New York State Office of Mental Health criteria have been rewritten to require use of professional society criteria, not proprietary for-profit, developed by the insurance industry, acuity-based criteria. Interqual and MCG are not very different when all is said and done from the United Behavioral Health criteria. They don't meet the sniff test of the 8 elements of effective treatment. They're not multidimensional.
I'm mindful of time, but it wasn't so much a question, but more of a comment. And I think that this is such a wonderful comment and a good idea. During the pandemic, there was a stimulus package that was signed that required insurance providers to provide information on NQTLs to federal regulators and upon request by state regulators. So I think that we can all encourage each other to reach out to their state insurance regulators and request data and make it publicly available, because when there's transparency, there's more accountability, and accountability leads to change. And then, to go back to sort of my first comment or question after your presentation is, what are little things or big things that we can do as clinicians? And making this request, I think, is certainly important. We need to be holding these companies accountable, and there does need to be transparency with what is going on. And also we need to be questioning, this is part of just a bigger topic, a bigger umbrella issue, which is that mental illness is still very stigmatized in our society, and mental illness does not get the same treatment or care that medical illnesses get. If you look even at this week, somebody like Naomi Osaka, she was fined and banned from participating in a tournament because she suffers from depression and didn't want to do press. But that if she broke her leg during the match and said, sorry, I can't do press, they would say, oh, of course. And there would be no fine, no banning from a we are in a time where we are in a mental illness crisis after a pandemic. And it's time for us as mental health providers to make sure that we're advocating for the needs of our clients, because they deserve to get the same treatment and to be viewed with the same sensitivity as somebody who struggles with diabetes or cancer, et cetera. So with that said, Eric, was there anything else that you wanted to close with before I ended? Because we have about 3 minutes.
Well, I mean, the point that you began with is an important one. This December 2020 Consolidated Appropriations Act is a really big deal, requiring the insurance companies to issue their own mental health parity compliance report card. That actually came from a piece of legislation called the Mental Health Parity Compliance Act that those of you who are from Connecticut should be very happy with your Senator Chris Murphy, who worked with a Republican senator from Louisiana to make this a bipartisan law, and it became part of this combined consolidated act. It's very important, and it is an important point. Sunlight is the best disinfectant, and ultimately insurance companies will be held to account when it's made public if they're not complying with the terms of the parity law.
Yeah. Thank you so much for this super important conversation. We're honored to do this with you, and I hope that we all continue this conversation in the future. I wanted to let everybody know that our next roundtable event will be on Thursday, June 17th, with Dr. Adriana Westby from PCH, and another super important topic will be discussed, which is racism, drugs, and our role in social change, really focusing on how the war on drugs has had a devastating impact, particularly on communities of color. And we really look forward to seeing everybody there, and again, collaborating as mental health professionals in this field to create broader systemic change. So thank you all. Thank you, Dr. Plakun.
You're welcome. Thank you. Bye-bye.